question was which drug, dasatinib or nilotinib. Currently, we could add bosutinib to that list. I chose dasatinib because he had a chronic elevation of bilirubin. Nilotinib can do this also, and I just frankly didn't want to be confused. It worked. He had major symptomatic improvement. He had an extremely rapid molecular response. Currently, he has very low PCRs to undetectable levels. He's doing terrifically, has a poor performance status of 0, and in fact, he is now inquiring about stopping therapy. I told him I would not recommend it. Tim showed you the data about stopping in people who had been switched because of failure, and the risk is higher, particularly perhaps in someone who had clonal evolution. In June of 2011, somewhere in here, he had a positive stress test. He had left anterior descending stenosis. He went to the plumber. He had stents placed. He's fine at the moment, but we did not know about this cardiovascular problem at the time. We didn't attribute it to the drug. And so the issue when you're switching or when you're starting is considering longer-term side effects. Late pleural effusions with dasatinib, show you that in a moment. Rare pulmonary hypertension. Nilotinib can turn you diabetic or make your diabetes more difficult to manage. And there's an appreciable incidence of peripheral arterial occlusive disease and other arterial thromboses. There's less information about bosutinib, but Mike Deininger just showed you a red flag from the before study. And of course, we know about ponatinib. The nilotinib data I find incredibly striking. These are from the INEST-ND studies, where the cumulative incidence of cardiovascular events was 15% at 400 milligrams compared to 8% at the lower dose. But these numbers will only get higher. They can't get lower. And some of them are called grade 1 or grade 2, but I have no idea what grade 1 angina is or grade 2 angina is, and I sure as hell don't want it to happen to me. Whereas imatinib was extremely low. In the large German study, they looked at, with imatinib, vascular events were very, very low at 0.3%, probably background noise. With dasatinib, I'll show you a patient in a moment. Pleural effusions can occur generally early, but often late. And you have to be aware of that when you're following your patients. But this was a large follow-up study of about 800 patients on imatinib that showed a normal survival in people who had been in complete cytogenetic response at 2 years and almost no cardiovascular events. This is a second case. She was diagnosed more recently in chronic phase. She was begun on 400 milligrams of imatinib. She had insulin-dependent diabetes. Her imatinib was held by her primary referring physician because she had diarrhea and significant thrombocytopenia. Instead of trying lower dose imatinib, the doc prescribed nilotinib. She promptly developed abdominal pain, increased lipase. Nilotinib was restarted at lower dose. She developed the same symptoms, and fortunately, this was self-limited pancreatitis, but obviously nilotinib could not be continued. We saw her and began her on dasatinib, 100 milligrams, decreased to 70 milligrams because of diarrhea and thrombocytopenia, repeating the pattern that she had with her previous drug. She had a very rapid response, and until 2010, her PCR was undetectable, and then it bounced around, but always at levels of better than a major molecular response, and we thought we were in the realm of well baby care. Late in 2014, she developed dyspnea and a substantial pleural effusion, which required thoracentesis. So pleural effusions can develop late, And you must tell your patients about this, because if they show up at an ER with this or to a pulmonologist, they're not going to know that this occurs. They'll keep them on the drug. And I had a patient who almost was referred for a pleurodesis because of refractory pleural effusion, and all that was necessary was stopping the dasatinib. You have to tell your patients about this. The effusion approved. Because of a good response, we tried dasatinib at a lower dose, rather promptly. Actually, this year is correct. It's 2014. The effusion worsened again, and we discontinued the dasatinib, and we began her on bosutinib. At that time, the record dose was 500 milligrams. Interesting, bosutinib is, the monster cause of diarrhea. It's the one that's associated with the most profound diarrhea. She had had diarrhea in the past. We told her that she's going to need frequent trips to the bathroom, and despite that, she had minimal diarrhea. So it's fascinating that sometimes history does not repeat in the same patient. She came back after being on the drug for about 9 months, dyspneic again, and the effusion had recurred. And as we were sending her for a thoracentesis, she reminded us that we told her that pleural effusions don't occur with bosutinib, except when they do. We were sort of running out of drugs, and when the effusion resolved, we restarted bosutinib, but at a very low dose. We monitored her very, very carefully because we had no idea whether it was sort of the competition. Would the effusion come back? Would the CML come back at the lower dose? She remains on 200 milligrams with PCRs that are always better than a complete cytogenetic response and sometimes better than a major molecular response. I have 2 or 3 other patients similar to this who are on extremely low doses of bosutinib with an excellent response maintained. And remember, you don't need a complete molecular response or even a major molecular response to do well forever. The bottom line is that one dose does not fit all. The recommended doses are not necessary for every patient. And when you encounter difficulties like the ones I described in this particular patient, you can drop the dose. If they maintain the response without the toxicity, keep them on the lower dose. This is my last slide. This is what my solid tumor friends call treating CML with a pill or a vitamin, that it's easy, anyone can do it, and I guess the point of this this lecture was to remind you that there are complexities. They change over time. Late toxicities can occur, and you just have to sort of know what you're doing in order to maximize the benefit for individual patients. Thank you very much.